Okay, rectal cancer, page number 1378 எடுத்துக்கோங்க. Rectal cancerல அந்த 1378ல ஒன்றும் இல்லை. என்ன சொல்றேன்னா யூஎஸ்ல there is increasing number of young patients being diagnosed with rectal cancer. அப்புறம் லாஸ்ட் லைன், rectal cancer have much higher incidence of local recurrence. So local recurrence is higher in the rectal cancer compared to the colon cancer. So next, so circumferential margin of resection, it is difficult in this rectal cancer. Next to MCQs, the lower half of the rectum drains into the systemic circulation and therefore can also metastasis through the systemic circulation to the lung, whereas upper rectal cancer tend to metastase just as colon cancer do through the liver. So lower half of the rectum most commonly metastasis to the lungs through systemic circulation. Next, coming to the physical examination. Physical examination, if it is palpable at the tip of the finger, one can ascertain whether there is good anal sphincter tone, in which case, in the majority of the patients, the cancer will be amenable to treatment by a sphincter sparing approach. So in a case scenario, if they have given like the lesion is palpable with the tip of the finger, then it means that you have to go for a option answer as a sphincter sparing approach. Okay, then so physical examination, we are always have to tell it as either anterior, posterior, left or right. Documentation using the 6 o'clock or 12 o'clock is confusing. So we never know how the patient was examined, whether in prone position or supine position. Okay, so the last paragraph. So flexible endoscopy are notoriously inaccurate. Okay, because so best is rigid endoscopy. Okay, then coming to the examining position, it is the knee chest position is particularly benefit, especially in the extremely obese patients. Okay, examining the patient on a tilt table in knee chest position is beneficial, as even in very large patients this permits a fairly good digital examination and examination of the lower rectum. Then coming to the staging of the rectal cancer, there are two investigations. One is endorectal ultrasound and MRI. So endorectal ultrasound is much less expensive. We'll think like it is more superior investigation than MRI and costly, but it is not. Okay, it is less expensive and can be performed without sedation. Okay, and provides an accurate assessment of the T stage of a rectal cancer. So only for T stage, endorectal ultrasound is useful. So in the diagram, you can see there are 5 lines, 3 white lines and 2 hypoechoic black lines. Whereas the innermost line represents the interface between the water-filled balloon and the transducer. So the transducer rotates 360 degrees to give the image of the rectum. In most studies, the accuracy of the lymph node detection is much less than the accuracy of the T stage. So endorectal ultrasound is better for T stage compared to the end staging. Then compared to the MRI, MRI is there is a protocol in which the MRI is accessed in the same axis as the rectum. It is very helpful to fill the rectum with the ultrasound gel mixed with gadolinium. Okay, so MRI interpretation, so each has both as advantage and disadvantage. So both endorectal ultrasound and MRI. A pelvic MRI will however permit assessment of the lymph node involvement and circumferential resection margin status, as well as assessment of the extrarectal disease, which is not possible with the endorectal ultrasound. Currently, clinically T3 and node positive rectal cancer, T3 and N+, and those cancer in close proximity of the sphincter, in whom sphincter sparing approach are desired to recommended to undergo preoperative neoadjuvant chemoradiation. Okay, so T3 and N+, from T3 and N+, we have to start with the neoadjuvant chemoradiation. So in MRI, I've written 2 points. One is this: no IV contrast needed and no enema is also needed. Just a filling with this ultrasound gel mixed with gadolinium is enough. We can use stimulations like buscopan or glucagon if needed. And the best investigation will be the surface coil MRI. So next page. So according to German rectal cancer study, what they have told is T3 and T4 rectal cancer patients were randomized to receive either preoperative or post-operative chemoradiation. So there was no overall difference in the morbidity and mortality. However, lower rate of local recurrence and both acute and long-term toxicity was less in patients with preoperative treatment. So this can be a true or false statement. Both are equal only, preoperative or postoperative chemoradiation. But why we prefer neoadjuvant is lower recurrence and lower toxicity. So next, coming to Haber-Gamma phenomenon or Haber-Gamma protocol. Okay, so this tells about the waiting amounts from the completion of the chemoradiation until the surgery. So Professor Haber-Gamma has been, he told that wait and watch policy, because of many, almost 20% of the lesions will show a complete pathological response. So he told we can wait and watch. So just remember, Haber-Gamma phenomenon or protocol is for rectal cancer, and it states, it tells to wait and watch after the neoadjuvant therapy. So the complete pathological response, preoperative neoadjuvant, it was noted that 27% of the patients had no clinically detectable evidence of cancer following this treatment. So there was no difference in the local or systemic recurrence between the groups. That is, the patients who underwent neoadjuvant alone compared with neoadjuvant with followed by surgery. When comparing these two groups, there was no difference in the local or systemic recurrence. Okay, so approximately 20% patients who undergo neoadjuvant chemoradiation will achieve a complete response. This is currently not the standard of care. Even though Haber-Gamma told all these things, this is not in protocol right now. The absence of the luminal disease does not imply the absence of disease, and such patients must be followed longitudinally, not only with physical and endoscopic examination, but also with cross-sectional imaging, preferably MRI. Even if we adopt such approach, we have to repeatedly follow up the patient with MRI. With respect to response to neoadjuvant therapy in patients undergoing resection for rectal cancer, there has been different staging system proposed to grade the degree of tumor regression. So scale ranges from 1 to 3. 1 means complete response and 3 means minimal response. So next, coming to the treatments, first is local excision. So local excision, we have endoscopic approach and transanal surgical approaches. So endoscopic approach include the routine polypectomy, endoscopic mucosal resection, endoscopic submucosal resection, all these things. Surgical excision can be performed via standard transitional excision, that is transanal MIS, TAMIS, as well as by transanal endoscopic microsurgery. This is called TEMS. So two things are there, TAMIS and TEMS. So next, coming to the lesions and their removal. Coming to the benign lesions will be soft when we touch. So most commonly this is particularly applicable to the villous adenomas of the rectum. So these are amendable to the transanal excision or endoscopic excision. So next, they are discussing about the technique of how we do the endoscopic submucosal resection. It is similar elsewhere. Okay, same kind of procedure, submucosal injection, then we use suction, then we use a snare, and we remove the lesions. Okay, like a routine polypectomy only. So next MCQ is, when lesions go somewhat deeper through the muscle wall, a technique called as the endoscopic submucosal resection. The first thing I told is endoscopic submucosal excision. When muscle is invaded, then we can go for endoscopic submucosal resection can be performed. So traditional criteria for performing a local excision for a rectal cancers. So less than 2 centimeter in diameter lesions, well differentiated cancers within reach of the index finger. Okay, and lesions that are mobile, that is not fixed. So T1 lesions are ideal. T2 or T3 are not suitable because recurrence rate is unacceptable. So if traditional local excision is performed, cautery is used to score a 1 centimeter margin around the lesion. So traction is used and a full thickness incision is performed down to the perirectal fat. So till what layer we will do this local excision is till the perirectal layer. So local excision is safe in the tumors located in the lateral or posterior to the rectum due to the presence of the mesorectum. So these procedures are almost most safely performed in the lower rectum. So local excision procedures are more safer in lateral or posterior rectum and especially in the lower rectum. Next, coming to TAMS, transanal endoscopic microsurgery. So with this, we can excise the larger lesions, and lesions higher than could be safely performed using the conventional transanal surgery. Okay. This technique has now largely been supplanted with the technique of TAMS, whereby standard laparoscopic instruments and an access port similar to that used for a single port laparoscopy is used in the anal canal to allow for the safer excision of the tumors. So due to the anchoring of the laparoscopic access device itself, this technique is not suitable for lesions in the very low rectum. Okay, you can see the diagram above, that is transanal excision of a small rectal cancer. Okay, using cautery, 1 centimeter has been spored off. Okay, so what I've written above is TAMS. TAMS is local excision transanally in high rectum, but it is not suitable for the very lower rectum. This is the carry home point. Okay. And TAMS, TAMES, I mean, TEMS, that is transanal endoscopic microsurgery, is now replaced by TAMS. Okay, so TEMS is not much used now, only TAMS is used. So resection for rectal cancer. So rectum is divided into proximal, mid, and distal 15 to 20, 10 to 5, and 5 centimeter less from the anal verge. So the upper portion of the mid rectum and distal rectum are extraperitoneal structures. So regarding the resection, the distal mucosa preservation is important because it is fundamental to discriminate between the stool and the gas. The mesorectum in turn is enveloped by the mesorectal fascia that has to be kept intact during the dissection because its integrity has been shown to be crucial to reduce the recurrence of the risk of the local recurrence. So Juvin already told while taking the anatomy. So when we see beneath the sacrum, anterior to the sacrum, we have the presacral fascia, and anterior to it, you'll get this fascia propria, which is enveloping the mesorectum. So in between those two areas, one more fascia, that is endopelvic fascia, I guess, that is will be present. That is only in a few centimeters. That is from sacral promontory till to S4 level only. That in between fascia will be present. So they will ask about the plane. That is, we have to include the fascia propria, that is enclosing the mesorectum. That is just anterior to the presacral fascia. So low anterior resection. So after vascular division, similar to the left colectomy, the peritoneal reflection of the rectum is divided at the level of the sacral promontory. So in LAR, peritoneal reflection is divided at the level of the sacral promontory, and the rectum with its proximal mesorectum is gently pulled anteriorly, entering the avascular cotton candy plane. That is the plane between the fascia of the mesorectum and the presacral fascia. So, okay, extra care should be taken to avoid injury to the hypogastric nerves. So we should not go beyond this presacral fascia also. We will injure the pelvic plexus and it will be difficult to control hemorrhage. So the dissection is continued distally, and the rectum and the mesorectum are divided 5 centimeter below the cancer. So this is important. How the distal margin of the rectum and mesorectum is 5 centimeter distal to the cancer, thus indicating a subtotal mesorectal excision. So the most distal part of the rectum is naked, that is not surrounded by the mesorectum, that ends a few centimeter proximally. This is just a fact. Okay, mesorectum will not completely surround the rectum. The lower half will be devoid of this mesorectum. So at this level, the rectum can be divided with the stapler. Okay, so this is called as thotomesorectal excision. So the integrity of the visceral fascia is a crucial point that defines the quality of the TME, and it's directly related to the disease-free survival interval. Okay. The proper excision along the anatomical plane is essential in order to obtain the free circumferential radial margin, thus reducing the local recurrence rate below 5%. Okay, so TME with circumferential free margins the recurrence rate is less than 5%. It also results in a significant decrease in the frequency of the, not only the recurrence rate comes down, but this frequency of the urinary and sexual dysfunction also comes down. So recent studies tells that laparoscopic approach has similar results with regard to the quality of the resection, clear circumferential margin and recurrence rate when compared to an open approach. So coloanal anastomosis is made with the help of the circular stapler inserted transanally. Air is then insufflated and the pelvis will be filled with water. So we have to check for any leak while doing this anastomosis, and a divesting loop ileostomy is usually made, and it is maintained for at least 8 weeks. So so the time of reversal of this loop ileostomy is after 2 months. So sphincter sparing surgery procedures for the low rectal cancer. So tumors in the ultra-distal portion of the rectum, that is at the level of the dentate line or below it, are a specific entity due to their proximity to the anal sphincter. Okay, in young and fit patients with good preoperative sphincter function, if the sphincters are not infiltrated, then sphincter sparing approach is the standard of treatment. So, and an anastomosis between the colon and the anal canal should be done. So, the ultra-distal rectum cannot be stapled from the abdomen. So, therefore, the dissection and the reconstruction, everything we have to do transanally. So, different types of dissections can be done. With the standard mucosectomy, the distal mucosa is peeled off of the internal sphincter. Okay, the distal mucosa should be peeled off in such cases when we perform a sphincter sparing surgery. But 1 to 2 centimeter of mucosa about the dentate line should be preserved. I already told, because that portion of the mucosa will differentiate between the gas or stool. So it is more important to preserve the distal 1 to 2 centimeter of the mucosa above the dentate line in sphincter sparing surgery. With this dissection, the internal sphincter that lies underneath the mucosa is spared. This is sphincter sparing approach. So an asymmetrical mucosectomy can also be performed en bloc with the underlying internal sphincter on one side of the anal canal, sparing part of the distal mucosa and sphincter. You can see in the next page, okay, 52.76 diagram, asymmetrical resection. That means asymmetrical resection means one side of the internal sphincter will also be, traditionally in sphincter sparing, we won't remove the internal sphincter, but in case of one side involvement of the tumor, we can remove the mucosa along with the internal sphincter on that side alone. Okay. If the cancer involves a larger part of the anal canal, an intersphincteric dissection must be done. With this dissection, the internal sphincter responsible for the resting pressure of the anal sphincter is removed circumferentially. Okay. Next, we'll see about the transanal total mesorectal excision. So in this diagram, you can see this is the asymmetrical excision, sphincter sparing surgery. When the sphincter is, when the larger part of the anal canal is involved, then we go for a intersphincteric dissection. So after intersphincteric dissection, all the patients show a decrease of the resting sphincter pressure, but the squeeze pressures are unchanged. So squeeze pressure is important for defecation. So that will remain unchanged and the functional results are acceptable. Next, coming to the abdominal perineal resection. If the sphincters are infiltrated by the tumor, complete excision of both the rectum and the anus along with the sphincter sparing apparatus must be performed along with the creation of the permanent colostomy. It is also known as the Miles procedure. So it is also a procedure for elderly patients with distal cancer with poor sphincter function. Okay, because end colostomy offers better quality of life. So regarding the surgery, you can see in the next page, there is a diagram in it. So where all will divide the structures, the IMA is divided. Okay, then the colon will be mobilized and it will be divided above the rectosigmoid junction. So and the rectum is dissected using the traditional total mesorectal excision principles to the level of the levator ani. Okay, then so at this point, the perineal operation will begin. Pursing suture is placed around the anus and it is excised en bloc along with the sphincter. So where do we ligate these this hemorrhoidal arteries and all will be ligated along with these things. Okay. If wider perineal resections are needed, especially in irradiated pelvises that may have healing difficulty, the perineal defect can be closed with the rectus abdominis flap or gracilis muscle flap. So after this neoadjuvant therapy, neoadjuvant chemo radiation, we have to close the defect with the rectus abdominis flap or gracilis muscle flap. So APR carries intrinsic risk of higher recurrence. So this is something different. Okay, you might think APR we are removing entire thing, the recurrence rate will be less, but it has higher recurrence rate up to 33% compared to the lower rectum. So one reason for this, it might be the APR is done only for the more aggressive cancer and in advanced stages. But other reason is there is an intrinsic higher risk of specimen perforation and a higher rate of positive surgical margin in patients undergoing APR. That's why there is a higher risk of recurrence with APR compared to the LAR. So what is the ideal procedure is? So traditionally, we followed this procedure, which you can see in the diagram, a wide pelvis kind of lesion. But current recommendation is to excise a conical lesion. Okay, more cylindrical lesion, avoiding the coning towards the rectum should be done. Okay, so first the abdominal part of the operation will begin. Okay, then the patient will be rotated in a prone jackknife position. So a wide elliptical incision is made till the tip of the coccyx, which is removed along with the specimen, and the sphincter apparatus also removed en bloc with the riveter in a cylindrical manner. So coming to special circumstances. So in this diagram, you can see this is an important diagram, this transanal total mesorectal excision. Okay, you can see the laparoscopy ports placed. Okay. The next diagram shows the perineal. This is about the Miles procedure. Okay, APR. So coming to the special scenarios, synchronous cancers. In patients with synchronous cancer, depending on the site of the tumors, more extended resection has to be performed. So for synchronous cancer of the right and the left colon, abdominal colectomy with iliorectal anastomosis is indicated. Okay. The second cancer is the rectum. Then we can go for a total proctocolectomy with ileal pouch anal anastomosis. So next circumstances, short residual colon. So if we get a recurrent tumor or a metachronous tumor, while going for re-resection, the residual colon may be too short to reach the pelvis for a tension-free anastomosis. So there are two approaches how we can perform a tension-free anastomosis. First is that the colon can be transposed through a retroileal transmesenteric route. Okay, using this path, which is specially feasible in the non-obese patient, the colon is pulled towards the pelvis more medially, and we'll create a avascular plane in the mesentery of the ileum and pull it up. This will give additional 4 to 5 centimeter. That may be sufficient for a tension-free anastomosis. Another approach is to rotate the right colon. So to rotate the right colon, we have to divide the middle colic and the right colic vessels, which will prevent the mobilization of the colon. We'll divide the right colic and middle colic. So the colon is transected at the site of the ischemic demarcation, and the residual colon with its blood supply from the ileocolic pedicle is rotated counterclockwise direction, and it is mobilized to reach the rectal stump in the pelvis, and an anastomosis is performed. Okay, so this second procedure, first is transileal retroileal transmesenteric route. The second one is excising the rectum, that is dividing the middle colic and right colic, and then taking the segment of the colon which derives blood supply only from the ileocolic and performing an anastomosis. So coming to the complications of the surgery, so many complications are there. First one is the anastomotic leak or dehiscence. So incidence is 1 to 3% in ileocolic anastomosis, up to 20% in coloanal anastomosis. So compared to ileocolic, coloanal has more leak rate. What are the risk factors? Male gender, obesity, LAR, and ASA 3, 4, 3 to 5, emergency operation, intraoperative complication. So use of oral anticoagulant that you note. So the use of oral anticoagulants you noted down. So next thing is regarding the stoma. The presence of a diverting stoma does not decrease the risk of the leak, but it reduces its severity and lower the risk of reoperation. Okay, this might be a true or false statement. Diverting stoma decreases the risk of leak. False. Okay, it just reduces the severity and lowers the risk of reoperation. So next, coming to the investigation for detecting the leak, we have to give a gastrograph enema. Okay, so usually the leaks are detected during the 2nd and 7th pre or post operative day. Median time is 5.5 days, but 12% till up to 12% can appear 1 month, even after 1 month after the surgery. So treatment, if the leak is subclinical with minimal discharge and no systemic signs, it can be managed with close clinical observation, antibiotics, bowel rest, and TPN administration. 1 second. So if the small perianastomotic abscess is, so if it is a small leak and patient is stable, no systemic signs, just manage it conservatively. Just bowel rest, antibiotic, close observation is enough. If an abscess forms, if a small perianastomotic abscess is demonstrated with no abdominal collections or free air and without systemic symptoms, an attempt of percutaneous drainage should be made with close clinical observations. Okay, no peritoneal collection should be there and no free air should be there and no systemic symptoms should be there. In such small abscesses, percutaneous drainage is done. Okay, in patients with signs of peritonitis or sepsis, we have to re-explore. We have to abdominal exploration allows a peritoneal lavage and a reposition of the new drains if needed. So laparoscopical approach may be preferred in order to minimize the septic complications of the abdominal wall. In left-sided colectomies, intraoperative endoscopic exploration of the anastomosis is helpful to determine the extent of the leak, and it also allows the colonic lavage. So laparoscopy has the added benefit of exploring the anastomosis, and we can give a colonic lavage before performing the re-anastomosis. So if the leak is less than 1/3 of the anastomosis and abdominal contamination is minimal, a diverting stoma may be sufficient. Okay, so this is in patients which presents with systemic signs or peritonitis. We have to see how much is the leak. If it is less than 1/3, just to do a stoma, and stoma creation is is disrupted, it has to be dismantled with the creation of a terminal stoma. An ileocolic anastomosis in right-sided resections can be ideally managed by redo of the anastomosis. So that's it about the leak. Then next, necrosis of the transposed colon. So in this, the keyword is foul-smelling material in the perianastomotic drains. We can see. So this manifestation of the ischemic injury of the transposed colon. So it should be differentiated from a simple dehiscence because the treatment must be more aggressive. So we have to dismantle the anastomosis and we have to create a terminal stoma for necrosis of the transposed colon. Next, coming to bleeding. So minor bleeding, major bleeding. Minor bleeding is more common, okay, after which is observed after the first bowel movement. Major bleeding with hemodynamic instability will require a resuscitation, blood transfusion, and active treatment can occur in up to 4% of the cases. So usually the bleeding will be from the small arterioles at the staple lining. So treatment is usually endoscopic with positioning of the clips at the suture line, adrenaline injection, or electrocoagulation. Next, twisting. So twisting almost exclusively occurs in the extracorporeal ileocholic anastomosis after the laparoscopic hybrid right colectomies. Okay, so if the anastomosis is twisted because of the edema, there will be obstruction kind of things. So if it is a left untreated, it can become gangrene. So immediate redo of the anastomosis is necessary. So remember, for necrosis of the transposed colon, we are creating a terminal stoma. For twisting, we are redoing the anastomosis. For bleeding, local control. For leak, only if it is more than 1/3, we go for a redo anastomosis or creation of a terminal stoma. Next, coming to the stricture. So risk factors for the strictures are use of a small diameter stapler. So 25 millimeter circular stapler should never be used in colorectal anastomosis in adults. So other thing risk factors are anastomotic leak, ischemia, radiation and all. So treatment will be usually endoscopic with balloon dilatation or placement of radial incisions or positioning of endodenal stent. Okay. So redo anastomosis not amendable to not responding to the endoscopic treatment should be done. So only in cases in which endoscopic measures fail, we have to go for a redo anastomosis. One second. So next one is lower anterior resection syndrome, LAR syndrome. It is a consequence of LAR and coloanal anastomosis, and it is present in 80%, maybe present in 80% of the patients undergoing a LAR. So syndrome is characterized by mixture of multiple symptoms, that is frequency, multiple fragmented bowel movements, sense of incomplete emptying, incontinence, constipation, diarrhea. Remember, both constipation and diarrhea can occur in the LAR syndrome. So most of the symptoms improve 1 year or more after the resection. Okay. So the cause is multifactorial. So injury to the internal sphincter, loss of sensitivity of the anorectal mucosa, loss of impairment of the rectoanal inhibitory reflex, then reduction of the capacity of the rectal reservoir, and loss of compliance of the transposed colon. So all these are risk factors, causes. So the incidence is higher in patients undergoing the TME. So LAR plus TME has higher incidence. In those with coloanal anastomosis, in those who received neoadjuvant chemoradiation, and those who had anastomotic complications. They have given almost all the complications here. Okay. So preventive technical mechanisms, what are we have to do is to improve the LAR symptom is anastomosis with a 5 to 6 centimeter colonic J pouch creation. We saw in IBD as well, the best pouch is J pouch, length is 5 centimeter. So similarly, J pouch is created, or with transverse coloplasty or side to end colorectal anastomosis. So 3 measures can be done. Okay. So we can see the diagram, that is the coloplasty. Okay. We give a longitudinal incision and close it transversely, and side to end colorectal anastomosis can also be done. The coloplasty is a possible alternative in obese patients in which the J pouch does not fit into the narrow pelvis. So in obese patient, coloplasty preferred more than J pouch creation. So the treatment of LARS is often empirical based on the diet control, balanced use of loperamide along with fiber diet, physical therapy using biofeedback, and transanal irrigation. In a minority of the highly symptomatic patients with low quality of life, construction of a stoma can be necessary as a definitive treatment. Okay. Next, coming to the post-operative treatment and the follow-up. So majority of the recurrence will occur within the 2 years. So CEA levels we have to obtain every 6 months for 5 years after the surgery. Every 6 months for 5 years, and then annually. This has been asked in a test series. There is colonoscopy should be scheduled 1 year after surgery. But if the entire colon was not completely investigated at the time of the diagnosis, then colonoscopy is performed after 3 to 6 months after the surgery. So further colonoscopy is repeated every 3 months if no adenomas were detected, and every year if adenomatous polyps are found until the colon is found clean. Next, coming to the post-operative treatment, stage-wise treatment. Stage 1, that is tumor invades the muscularis propria with negative lymph nodes. Follow-up alone is the appropriate choice. Coming to, so stage 2 tumors. Stage 2 tumors means it penetrates into the pericholic fat and with the negative lymph nodes. So in the absence of risk factors, so we no need to give any chemotherapy or nothing. In stage 2 colon cancer also, okay, with the potential risk factors, it is a relative indication for chemotherapy only. It is not must that stage 2 patients with high risk factors should receive adjuvant chemotherapy. So what are the risk factors is poorly differentiated cancer, grade 3, grade 4, perineural and vascular invasion, obstruction, perforation, adjacent organ invasion, and inadequate number of examined number of lymph nodes. So you can see in the next line, even in these high-risk patients, no definitive value for adjuvant chemotherapy has been demonstrated, and the addition of the oxaliplatin does not add any benefit. So next, coming to the MSIH condition. So even though we are using adjuvant chemotherapy for such risk factors in stage 2, it is not must. MSIH condition, okay, that is deficient expression of the MMR gene, is more frequent in stage 2 disease than in stage 3 disease. Okay, and does appear to have a favorable prognostic significance in stage 2. Just remember, MSIH, okay, is more frequent in stage 2 diseases compared to stage 3. Coming to the stage 3 diseases, that is lymph node positive conditions, 2 chemotherapy regimens are there. One is FOLFOX, another one is CAPOX. CAPOX means oral capecitabine is used instead of the 5-fluorouracil treatment. So they have confused you with so much things. So actual summary is FOLFOX we have to use 6 months. Okay, they are comparing 6 months and 3 month regimen of both these things. So FOLFOX is a 6 month regimen is better, whereas CAPOX 3 month regimen is sufficient. Just remember that. So what are the low risk patients and high risk patients in stage 3? Low risk patients means pathological T3 and pathological N1. High risk patients are pathological T4 and NEN. Okay, so in low risk patient, 3 month of CAPOX was not inferior to the 6 months of the same regimen. Similarly, with regard to FOLFOX, 6 months regimen superior to the 3 months regardless of the risk group. One has to remember, however, that these are unexpected findings because a comparison between the treatments was not pre-planned. So next, coming to the metastatic disease. So in metastatic disease, the possible chemotherapy regimens are as follows. So first one is anti-EGFR antibodies. That is panitumumab and cetuximab can be used in pan-RAS wild and BRAF wild type neoplasia. Okay, so pan-RAS wild type and BRAF wild type neoplasia, anti-EGFR antibodies are used. Next, standard treatment in BRAF mutated metastatic diseases, administration of folfoxiri. Folfoxiri means oxaliplatin, irinotecan, and 5-fluorouracil and folinic acid and bevacizumab. Okay, so BRAF mutated patients have the worst prognosis. So BRAF mutated, if it is wild type, you can give anti-EGFR. BRAF mutated, simply BRAF mutated metastatic diseases, we have to use for the folfoxiri regimens and bevacizumab. So if the primary tumor is right-sided, anti-EGFR antibody is given in addition to the folfox or folfiri regimen. Are not superior to the chemotherapy alone in the first line treatment. So what they are telling is, for right-sided tumors, combining anti-EGFR along with the chemotherapy agents are not superior to chemotherapy alone in the first line treatment. Okay, so for fit patients, growth factor antibody bevacizumab could be the best choice. So if the patient is fit, we can combine this VEGF bevacizumab along with folfoxiri. Okay. If left-sided primary tumor, the addition of the cetuximab or panitumab to folfox or folfiri could be the first line of treatment. So for right side, along with Folfox or Folfiri, we don't combine the anti-EGFR antibody, whereas in left side tumor, cetuximab is added with Folfox or Folfiri. Okay, that is the difference. So in older or unfit patients unable to tolerate the doublets, capecitabine with bevacizumab is an appropriate treatment. So in case scenario, we have to see what is the age of the patient. If it is an older or unfit patients, then just capecitabine with bevacizumab is enough. Okay, if he is a fit patient, then triplet regimen along with bevacizumab can be used. If it is a left-sided lesion, then you have to add cetuximab or panitumab with Folfox or Folfiri, whereas it is not needed for the right-sided tumors. So that's it with rectal neoplasia. Next, coming to the benign conditions, pelvic floor disorders and the constipation. So first, what is constipation? So constipation is a dysfunction of the colonic motility and of the defecation process. So pelvic floor disorders that present to the surgeon are rectal prolapse or prosidentia, rectocele, cul-de-sac hernia, and anismus. Cul-de-sac hernia is protrusion of peritoneum between the rectum and the vagina. Okay, so it is referred to as enterocele or sigmoidocele. So anismus, know the meaning. The failure of the puborectal is an external anal sphincter to relax during the defecation. That is simple non-relaxation or paradoxical contraction of the puborectalis and the external anal sphincter. That is anismus. So coming to diagnosis, so anorectal physiology laboratory tests are there. 4 tests are there. First one is anorectal manometry. So manometry will measure the resting pressure. So resting pressure is mostly due to the internal sphincter. Then we can see the maximum voluntary pressure, squeeze pressure due to the external anal sphincter. So normal resting pressure is 40 to 80 millimeters of mercury. So it also provides information about the intrarectal pressure, reflexes, rectal sensation, and rectal compliance. So high resolution manometers will provide physiological resolution and it minimizes the motion artifacts. Next, balloon expulsion test is ability of the patient to expel a balloon inflated with 50 to 60 cc of water, gas, or air that stimulates the stool. Next, pudental nerve terminal motor latency test. Normal is 2 plus or minus 0.2 milliseconds. Okay, so in this, what we do is we attach this device to the index finger. Special electrode will be taped to the index finger, whereas the recording electrode will be placed at the base of the finger. So it will. Next is electromyography. Electromyography is for depends on the basal electrical activity from the external sphincter and the puborectalis muscle. Next, imaging. Imaging, first one is endoanal ultrasound. Second is difficography. So difficography is a dynamic study of the anorectum and the pelvic floor during the defecation. Dynamic images will be captured during the fluoroscopy. Okay, with the vagina and the rectum being opacified with the radiographic contrast materials. So a number of conditions can be diagnosed using the difficography. So if MR difficography is performed, similar to the we saw in rectal cancer MRI, ultrasound gel with gadolinium is placed here also. So however, limited by the supine portion of the pavement that does not reproduce the normal condition of the defecation. So MRI, we have to place the patient in a supine position. So it is not that better compared to the traditional dynamic difficography. Next, colonic transit time. So how to see the colonic transit time? So 24 radio opaque marker containing capsule. That capsule is called as the SIPS marks. Okay. So this has to be ingested and the patient should be refrained from using laxatives and other mechanical measures that interfere with the colonic function. So normally 80% of the marker should be expelled by day 5. So, okay, every day the images are taken until day 7. So 80% of the marker should be expelled by day 5. That is normal. So coming to the pathologies, first one is rectal prolapse or prosidentia. So it can be an internal rectal prolapse or intra-anal prolapse or 2 external anal prolapse. So more common in the woman older than 50 years. If it occurs in men, it is usually younger than 40 years. So young patients, both male and female, they suffer from psychiatric disorders or autism or develop delay, and they take the constipation medication. So what are the defects we can see? Diastasis of the lever trani muscle, an abnormally deep cul-de-sac, redundant sigmoid colon, patulous anus, and lack of facial attachment to the rectum against the sacrum. So risk factors, previous pelvic surgery, female gender, more than 40 years, chronic straining, constipation. Point to note is chronic diarrhea. Chronic diarrhea is also a risk factor for the prosidentia. Then vaginal delivery, multiparity and all. So pelvic floor dysfunction, psychiatry illness, diseases that requiring constipation medications, all these things are seen. So you can see here the normal anorectal manometry. So one MCQ we can expect is what are the things we see in this anorectal manometry. We can see the resting pressure, squeeze pressure, external anal sphincter relaxation, not contraction, external anal sphincter relaxation, and RAIR is rectoanal inhibitory reflex. So coming to it's usually a progressive disease. It prevents from, first it will be self-reducing, then first it will be self-reducing, then it will require manual reduction, then stable prolapse, then ulceration, and finally incarceration and necrosis in the advanced cases. So symptoms. So the majority of the symptoms of patients with rectal prolapse is fecal incontinence. Passive or urge incontinence will be seen. Okay, up to 1/2 of the patients with incontinence have also pudental neuropathy. 25 to 50% of the patients, and particular those with intrarectal prolapse, report constipations or obstructed defecation. Next, diagnosis. Diagnosis is the true rectal prolapse should be differentiated from the prolapsed mucosa and prolapsed hemorrhoids. Okay, so how will you differentiate? Full thickness rectal prolapse has concentric folds, whereas the other two conditions will have radial folds with grooves along the hemorrhoidal cushions. So standard examining question is the left lateral decubitus sitting or squatting question. Proctoscopy examination should be done to, because 10 to 15% patients will have a anterior solitary rectal ulcer. Then proctoscopy will indicate the erythema, that is 5 to 6 centimeter, which is the leading edge of the prolapse. So when is MRI diffeography indicated? With coexisting disorders such as rectocele, cystocele, enterocele, sigmoidocele, we go for MRI diffeography. But colonoscopy should be performed, always performed, to exclude the presence of colorectal carcinoma or other colonic pathology. Then colonic transit study is also important for patients with lifelong history of constipation, to differentiate constipation from obstructed defecation and slow colonic transit. Then endoanal ultrasound, if you use, it will show thickening of the internal anal sphincter. So next page, you can see the diagram of this colonic transit study. Okay, up to 7 days, the images are taken. Next is one second. So regarding the non-operative management of rectal prolapse, so medical treatment is just for palliation only. We know all those things. Sugar or salt can be used to reduce the mucosal edema and facilitate reduction. So operative repair. Coming to operative, abdominal and perineal, two approaches are there. Coming to the abdominal approach, two things are there. One is posterior rectopexy, which is also called as the modified Ripstein's procedure. Another one is ventral mesh rectopexy. Okay, so the goal of the abdominal procedure is adequate upward tension, then appropriate evacuatory movements, both open and minimally invasive can be used. So MCQ here is posterior rectopexy. Where will you fix? We will fix to the presacral fascia and to the lateral rectum. Okay. Whereas in the ventral mesh rectopexy, we will fix to the sacral promontory and to the anterior wall of the rectum. That is the difference. So compared to these two things, ventral mesh rectoplasty is now better in the sense of post-operative incontinence and constipations, and a low complication rate and a recurrence rate. So use of biological mesh or synthetic mesh So there is no difference in the recurrence and complication between these two meshes. Next, coming to the perineal approach. So perineal approach will just resect the prolapse and we won't do a concomitant fixation. So first procedure is the Ultimus procedure. So recent studies, it tells that both are equal, perineal and abdominal procedure. However, mostly the abdominal procedures are preferred for the young and fit patients. Okay, perineal are done for the old patients and unfit patients. First, coming to the Ultimus procedure. So Ultimus procedure is also called as the perineal proctectomy or proctosigmoidectomy. So true rectosigmoidectomy. So full thickness circumferential incision is made through the rectum 1 centimeter above the dentate line. So redundant sigmoid colon is extracted transanally. The levator muscles will be plicated. One second. Okay. That's about Ultimus procedure. It can be performed in the epidural anesthesia. Next, coming to the Delorme's procedure. So Delorme's procedure is preferred for the short segment prolapse, that is less than 5 centimeter rectal prolapse. Delorme's here circumferential incision is made within the submucosal plane 1 centimeter proximal to the dentate line, and the mucosa is stripped away from the muscularis propria of the rectum to the most proximal portion of the prolapse. We'll strip off, then we'll excise the mucosa, then longitudinal suture plication of the muscularis propria is performed. Okay, final anastomosis is performed between the proximal and the distal mucosal procedure. So next procedure is for symptomatic intrarectal prolapse, STAR procedure, stapled transanal rectal resection. So that is not recommended according to the guidelines nowadays. Okay, that is given in the next page. So STAR procedure is not recommended by the ASCRC clinical practical guidelines. So next is solitary rectal ulcer. So it's a rare chronic benign disease, combination of symptoms. So mostly it will be multiple, 40% multiple, 20% single ulcer, common in young adults, female preponderance. Then cause is multifactorial. So where will you see the ulcer? 1 to 1.5 centimeter ulcer of the anterior rectal wall, 3 to 10 centimeter from the anal verge. It is difficult to differentiate from the rectal cancer. So HP will show few features. Okay, so if the patient is have mild to moderate symptom, medical treatment is usually effective. Surgery is reserved only for highly symptomatic patients, absolutely unresponsive to the medical treatment. So that includes excision of the ulcer, then treatment of any associated prolapse and defunctioning stoma who have failed the other options. Okay, so but unfortunately, many patients with SRVS will continue to have symptoms. Okay, regardless of the treatment. Next, coming to the rectocele. Rectocele is bulging of the anterior wall of the rectum into the posterior wall of the vagina. Risk factors are the advanced age, pregnancy, increased weight, hysterectomy, vaginal childbirth. So it is multifactorial. So most rectoceles are asymptomatic. So next, what is obstructed defecation? So the symptom is obstructed defecation. That means the cardinal symptom is difficulty in rectal emptying and the need to press against the posterior wall of the vagina or against the perineum in order to complete the rectal emptying. That is called obstructed defecation. It is seen in rectocele. So diagnosis is mainly on the clinical and the physical examination. Okay, if needed, defecography can be performed. Rectocele is of 3 types, that is small, moderate, large, less than 2 to 4 centimeter and more than 4 centimeter. So this diagram is important. They might ask, what is this? This is a defecating proctogram, okay, showing a rectocele. So it is important to realize that the degree of anatomic distortion often does not correlate with the degree of the functional impairment and symptom. Okay, so the anatomical and the symptom will not match. Even small rectoceles can have much higher symptoms. So asymptomatic rectoceles do not require treatment, while patients with symptomatic rectocele also, first we have to go for the conservative approach, bowel regimen and fiber products in order to improve the defecation. Only selected patients with markedly symptomatic rectocele unresponsive to medical treatment are candidates for surgery. So regarding surgery, The goal is to excise the redundant tissue of the rectocele, and we have to strengthen the rectovaginal septum. So there are various approach: transvaginal approach, endorectal approach, then transperineal approach, and all is there. Transvaginal, so these are done under local anesthesia. Okay, transvaginal fibromuscular layer is exposed and plicated in the midline. Okay, in endorectal repair, patient is placed in prone jackknife position. A T-shaped or midline incision is made in the rectal mucosa just above the dentate line. Just know the incision alone. Procedure on no need. The transperineal rectocele repair. Transperineal will place a transverse incision across the bulbocavernous and the transverse perineal muscles. So mesh can be placed in this transperineal rectocele repair. So this transperineal rectocele repair is indicated especially in patients with associated fecal incontinence, because a concomitant sphincteroplasty or levatroplasty can be performed. So if they ask rectocele along with the fecal incontinence, we have to go for a transperineal approach. Then coming to the last topic, constipation. So constipation, hypothyroidism, and medication-induced constipation are common cause. Patients should be counseled to increase the fluid intake. So polyethylene-based solutions, Miralax, then probiotics can be given. So stimulative laxatives such as the bisacodyl or senna should be avoided on long term. So locally acting chloride channel activator. So its name is lubiprostone. Lubiprostone is a locally acting chloride channel activator. Then guanyl cyclase agonist, that is Linzess. Then serotonin 5-HT4 agonist, that is Montegrity. These can all be used to treat the symptoms of constipation. Next important criteria, Rome 4 criteria. What is functional constipation? If 2 or more of the following symptoms are present during at least 25% of the defecation for at least 3 months. So what are the 3 things? First one is the symptoms: straining, lumpy, hard stool, incomplete evacuation, then need for manual maneuvers, then fewer than 3 spontaneous bowel movements per week. So these all symptoms is the first criteria. Second is the loose stools rarely present without the use of the laxative. Third thing is insufficient data for criteria for irritable bowel syndrome. If any 2 of the 3 are present for 3 months during 25% defecation, it is termed as the functional constipation. So in functional constipation, we have to do this colonic transit time. Okay, and we have to differentiate. So in patients with slow colonic transit, the bowel frequency will be very less, 1 to 2 per week to 1 per month. So colonic transit constipation may present with a megacolon on a plain X-ray. In highly symptomatic patients with the slow transit constipation who failed aggressive medical therapy and whose quality of life is severely impaired, surgical treatment is indicated. We have to go for colectomy and IAR or and all the resection procedures. In highly symptomatic, when medical treatment has been failed and the patient quality of life is impaired. So last, in the next page, nothing is there. Only one line we have to do. So we have to remember, that is the segmental colon resection based on transit time measurements are no longer recommended. So even if you go for a resection procedure, abdominal colectomy with IAR or colectomy with iliorectal anastomosis will be segmental conal. This, you remember this line alone. For slow transit constipation, segmental resection is avoided. Thank you.